Welcome everyone to Oxygen Therapy and Critical Care, the case-based series. Before we begin, just a few reminders. We will be using the chat function for question and answer today. To ask a question, the button is at the bottom of your screen. Just click chat. Please send all questions through the chat box and feel free to introduce yourself. If you have any technological issues or WhatsApp, and we'll be happy to assist. And the session is being recorded and your attendance is consent to being recorded. Thank you. So today we are on session 4. Today's topic is frequently asked questions, a roundtable on oxygen therapy and critical care. As usual, the session is being led by Dr. Peter Saria from the Comprehensive Community-Based Rehabilitation Tanzania. And with him, Dr. Janeth Suma, Dr. Gibbons Mwaki Samwe, and Dr. Leticia Komba. And with that, I will hand it over to Dr. Peter.
Okay, thank you very much, Dr. Alana. As I already introduced myself, my name is Dr. Peter Saria from CCBRT Hospital, Dar es Salaam, and I'll be just moderating this session today. And it's unfortunate that Dr. Gibbons has some issues and avoidable circumstances. He cannot join this afternoon session. Dr. Leticia has an emergency in theater. She was already prepared for the session, but there's an emergency. She may join us soon, in the session, as well as Dr. Rebecca from Bugando, anesthesiologist. Also, she will join us late in the session. But for the sake of time, we cannot continue waiting for them. I rather start, and then once they're here, they can just chip in and continue this presentation. So, Alana, you can share from your side, yeah?
Yep.
Okay, thank you. So for those who have already joined the session, please feel free to interact. This is not a lecture, it's just a session whereby we can interact and share the experience. Okay, Lilian, unanisikia? Lilian, umesema hautusikii, hapo natusikia sasa? Wengine mnanisikia, please?
Echo India, can you please make Lillian co-host?
Okay, so Dr. Rebecca is also here. So please, Alana, can you share the slide from your side, please?
Sorry, ma'am, can you repeat again?
Can you see my screen?
Yes, we can see this. Oh yeah, sure. I can see the screen now. Okay, kwa hiyo kama jamani tulivyokwisha kuambizana, today we have our session, monthly session, and today's topic is just a frequently asked questions. Kuna yale maswali ambayo tunakuwa tukijiuliza mara kwa mara, and these questions will be based more on the oxygen therapy, critical care, the ARDS, the basics of oxygen therapy per se. So, and this will be our objectives. This is the first part of the session. We're going to see on the indications, contraindications, definitions, as far as the oxygen therapy is concerned. So maybe we can start with the questions. Not number one, can respond to that questions. The question asks about which of the following are indication for oxygen therapy. Mwendeni kwenye chat box hapo mtuambie which of these options are the indication for oxygen therapy. Kama unavyoona hiyo poll, just click the correct answer. If it's A, just click A. If it's B, just click B. If it's C, click one option. Okay, I've seen there's some people who have just clicked hypoxia. Tunaona hapo Tunatoa dakika chache tu za ku respond to that questions, and then we'll see majority wamesema nini. Okay, so Alana, can you share with us the results of the poll? Okay. So as you can see, majority of them say the answer is B, which is hypoxia, as the main indication for oxygen therapy, and it's not hypoxemia or it's not hypercarbia. Only one who respond with option B, which say A and B, that is hypoxemia and hypoxia, are the indication for oxygen therapy. So kwa majibu hayo hapa basi, jibu sahihi ni D, kwamba hypoxemia and hypoxia can be the indications for oxygen therapy. Nategemea how will you define. Later in the session tutaona definition of hypoxemia, tutaona definition of hypoxia. Kwa hiyo tukumbuke tu hypoxemia and hypoxia can be the indications for oxygen therapy. Okay, can we proceed, Alana? Okay, question number 2. Are there contraindications? Are there contraindications to oxygen related to oxygen therapy? Tunapozungumzia kwamba tunampa mgonjwa wetu oxygen, tunajua kuna wakati tunaweza kwa anything can either be a contraindication or an indications, lakini tukianza kuangalia contraindication, je, kuna watu gani ambao hatuwapa oxygen, au kuna wakati gani ambapo tutatarajia kupata complications za oxygen therapy? Tunaomba pia turudi kwenye chat box yetu hapo, tuanze kuangalia hizo option mbalimbali ambazo zinaweza kuwepo hapo kwenye complications and contraindication for oxygen therapy. Okay, so Alana, can you take us please to the okay. Kwa hiyo kitu chochote jamani, lazima kuwa kuna indications na contraindications, na hii ni article ambayo inajaribu kuangalia kwamba ni injuries, I mean complication gani ambazo zinaweza zikatokea kwa mgonjwa ambaye unamzidishia oxygen. Pase unaweza kwa haraka ukasema kwamba hakuna contraindication ya oxygen therapy. Wagonjwa wote wale ambao wanahitaji oxygen, we have to put them in oxygen, lakini kama tukiwapa oxygen in excess ndio tunaweza tukaanza kuzipata zile complications. Sasa na complication gani ambazo tunaweza kuzipata ziko nyingi, hatuwezi tukazimention zote zikaisha, lakini nyingi zinatokana na kwamba zile at the cellular level inaweza katokea cellular injury kwa sababu ile oxygen toxicity ambayo tulidiscuss in the previous session. Yes. Au dogo ambao ndo wanakuwa wanaweza kupata zile premature, I mean neovascularization of the retina, wakapata upofu kwa sababu ya hiyo complication. Kwa hiyo ni article ambayo inajaribu kuonyesha kwamba although kwamba supplemental oxygen is valuable in many clinical situations, any excess inaweza ikatuletea madhara mbalimbali, na tutashare na nyie kwenye group, I mean kwenye link yetu hapo, mtaziona hizo complication ambazo ziko nyingi. Zinaanzia kwenye mapafu, unaweza kupata atelectasis, unaweza zika interfere with respiratory center kwa sababu most of the time respiratory center zetu zinakuwa driven by carbon dioxide, lakini unapokuwa na hypoxemia inaweza kukuletea shida kwenye respiratory center, ukaanza kupata shida ya kupumua, na pengine zinaweza zikata hizo hydrogen peroxide, I mean zinaweza ka form reactive oxygen species ambazo ndo zinaenda kusababisha cellular injury, unaweza kujipata unapata shida mbalimbali. Kwa hiyo complications zipo na tutashare na nyinyi, mtaziona kwa undani zaidi. Okay, all right, Alana, next please. Sasa baada ya kuona hizo indications, contraindications and complication of oxygen therapy, now let us discuss the difference between hypoxemia and hypoxia. Can anyone share with us in the chat box what could be the maybe what his thought or her thought about the difference between hypoxemia and hypoxia? Hebu mtu yote achati hapo kwenye chat box atuambie what could be the difference between hypoxemia and hypoxia. Just few sentences ambazo zinaonyesha tu tofauti. Nini utofauti wa hypoxemia and hypoxia? Anyone who can try? Peter Mlacha, unataka kujaribu? Tofauti wa hypoxemia and hypoxia, au Prosper Masawe? Okay, tumeona Prosper Masawe anasema kwamba hypoxemia is low level of oxygen in the blood and hypoxia is a low level of oxygen in the tissue. Hakuna namna tunaweza tukaelezea zaidi hivyo. Masawe, you're right. Kwa hiyo tunapozungumzia kwamba hypoxemia is when anything with ending with EMIN, we all know that it has to do with the blood. Kwa hiyo hypoxemia, that means we have low level of oxygen tension or we have low level of partial pressure of oxygen in the blood. Na tunapokuwa na kiwango kidogo cha oxygen, when there is a poor delivery of oxygen to the tissue at the tissue level, ndio tunaita hypoxia. Kama unakumbuka hapo juu tumesema the indication of oxygen therapy can either be hypoxemia or hypoxia. Kwa hiyo hiyo ndo tofauti. Alana, can you take us to the yes please, to the difference between hypoxemia and hypoxia.
Diagnosing and treating hypoxemia requires providers understand its definition and how to detect hypoxemia using pulse oximetry or arterial blood gas analysis. When we breathe, we pull air into our lungs. Room air contains 21% oxygen. When oxygen enters our lungs, it travels to the alveoli, where it diffuses from the alveoli into the pulmonary capillaries. Oxygen then either binds to hemoglobin within the red blood cells or diffuses oxygenation. Insufficient oxygenation is called hypoxemia. The rate at which oxygen is delivered to the cells and tissues of the body is known as oxygen delivery. Inadequate delivery of oxygen to the cells, tissues, and organs of the body is known as hypoxia. Every cell of the body requires oxygen for cellular metabolism. Lack of oxygen leads to cell death, tissue death, and organ dysfunction. The rate at which oxygen is removed from the blood and used by the cells and tissues is known as oxygen consumption. Oxygen in the blood can be detected a number of ways. The majority of oxygen is bound to hemoglobin. This is known as oxyhemoglobin. The saturation of hemoglobin can be detected directly using arterial blood gas analysis, or can be detected indirectly using pulse oximetry. When oxyhemoglobin is measured by arterial blood gas analysis, it is termed SaO2. When oxyhemoglobin is measured using pulse oximetry, it is termed SpO2. The small portion of oxygen that dissolves into the plasma creates an arterial oxygen tension or partial pressure and is known as PaO2. Pulse oximeters measure arterial oxygen saturation, termed SpO2. Hemoglobin bound to oxygen is termed oxyhemoglobin. Hemoglobin not bound to oxygen is termed deoxyhemoglobin. Pulse oximeters shine light through tissue beds, usually a finger, a toe, or an earlobe. Then they measure the amount of light that is absorbed. Oxyhemoglobin absorbs light at a different wavelength than does deoxyhemoglobin. The ratio of light absorbed by oxyhemoglobin versus the light absorbed by deoxyhemoglobin is displayed as a percentage by the pulse oximeter. Non-pulsatile venous blood and tissues also absorb light. However, These components are discarded by the pulse oximeter. The pulse oximeter only uses the values obtained from pulsatile arterial blood flow. Normal oxygen saturation by pulse oximetry is greater than 94%. However, when administering oxygen therapies, an SpO2 greater than 90% is usually acceptable. Pulse oximetry is non-invasive and painless for patients. Arterial blood gas analysis, termed ABG, directly measures arterial blood gases, oxygen and carbon dioxide. Values obtained from ABGs include the pH, the partial pressure of oxygen, termed PaO2, arterial oxygen saturation, or SaO2, the partial pressure of carbon dioxide, termed PaCO2, bicarbonate, and base excess. Blood gas analysis requires a blood sample from the patient, which can be painful.
Okay, thank you Alana. Kwa hiyo mpaka hapo tumeweza kuona utofauti uliopo kati ya hypoxemia and hypoxia, na tumeona the causes za hypoxemia. Hypoxemia causes yake kubwa ni pale ambapo kunakuwa na poor oxygen delivery kwenye mapafu. Kwa hiyo tunazungumzia issue ya ventilation, oxygenation inapokuwa sio nzuri, au unapokuwa na issue yoyote kwenye alveoli ambayo inazuia diffusion ya oxygen kutoka kwenye alveoli kwenda kwenye damu, na inaweza kukuletea hypoxemia ambayo tunaita ni AA gradient, au unapokuwa na shunt inaweza kuwa ni one of the cause ya kusababisha hiyo decrease ya oxygen kwenye blood ambayo ni hypoxemia. Lakini factors zozote zile ambazo zinaweza zikasababisha poor delivery of oxygen to the tissue, zote hizo zinaweza zikawa zinasababisha hypoxia. Kwa hiyo hiyo ndio main difference between hypoxemia and hypoxia na causes zake kama ambavyo tumeziona. Okay, so Alana, can we go back to our objectives? Okay, so can we go forward, please? Okay, so far we've seen the difference between the hypoxia and hypoxemic. Next, okay. All right, okay, so can you scroll up? All right, so another question is, which of the following are not clinical signs or symptoms of hypoxemia? So far we've seen the difference between hypoxemia and hypoxia. We have seen the definition of hypoxemia. Now, can any one of us tell me what is the, which of the following are not a clinical sign or symptoms of hypoxemia? I can bet you, I think all of you can get this question right. Kata hilo swali, which of the following are not a clinical signs or symptoms of hypoxemia? You can just click the option which you think is right. We have less than 30 seconds to respond to this question. Okay, so one of says loss of taste or smell. What about others? Okay, we have 3 of us. Okay, none of them have said A, B, or D. So all of them. Okay, stenosis retraction and accessory muscle use. Okay, we are looking for the one which is not a clinical sign or symptoms. So, okay, we have less than 10 seconds to respond. Okay, as you can see, okay, so Alana, can you share the details, please? Okay, so majority 4 out of 6 who have responded to these questions, they say loss of taste or smell is true. So tachypnea, dyspnea, sternal retraction and the use of accessory muscles, or sometimes altered mental status or restlessness. These are the signs, the clinical signs and symptoms of hypoxemia. When you have low level of oxygen in your blood, So the response for your body is to increase your respiratory rate so that you can compensate for the low tension of oxygen in your blood. So you become tachypnea, you become dyspneic. And also, depending on the cause, you may start using the accessory muscles or of the respiratory system, the muscles. So now you'll see now the sternal retraction and also the nasal flaring. You can see intercostal recession. You can see chest indrawing because your body is trying to compensate for the hypoxemia. And when there's severe low level of oxygen in your blood, that means even the brain will not get enough oxygen. So even your mental status may start to be deteriorated. There will be an altered mental status, but neither loss of taste or smell is the symptoms or sign of respiratory of hypoxemia. Unapokuwa unashindwa kunusa au kuonja, hiyo sio dalili ya kwamba kuna hypoxemia. Sawa jamani? Okay. Can we proceed, Alana? Alana, next. Okay, so what causes hypoxemia and hypoxia in a nutshell, I think we've already discussed this. Tukasema kwamba tunaweza tukazigrade katika sehemu kuu tatu, kwamba kwa tukianza na hypoxemia no, can you go up? Can you go up, Alana? Yes, tukianza na hypoxemia tu, just in a summary, ni kwamba oxygenation inaweza ikawa na ugonjwa FiO2 ndogo, fraction of inspired oxygen concentration inaweza ikawa ndogo, au effort yake ya kuventilate inaweza ikawa iko impaired, ama inawezekana kuna shunt kama tulivyosema, au inawezekana kuna anemia, anything ambacho ina prevent delivery of oxygen to the blood inaweza kuwa cause of hypoxemia kama tulivyoona. Kwa hiyo tukienda kwenye what are the normal range of oxygen saturation now, tumeshaona kwenye ile video, we have seen in the video and that anything below 94% is considered abnormal. Kwa hiyo the normal range of oxygen saturation for a normal adult, health adult should be more than 95%. Lakini tunajua there's some exception, especially for patients who have having COPDs. Kwa wagonjwa ambao wana COPDs, the oxygen saturation, their target should be at least 88 to 90%. Na kwa mama wajawazito kama tunavyoona kwa wengine. Kwa hiyo normal oxygen saturation inatakiwa above 94, lakini kuna situation ambazo, kwa mfano kwa wagonjwa wenye septic shock, kuna wagonjwa ambao wana hizo ARDS, kuna wagonjwa ambao ni wana COPDs, kuna mama wajawazito, kidogo their normal value or their range should be a bit tofauti kidogo na ile ambayo tunakuwa tumezoea. Now when we are talking about what is the goal for SpO2 when administering oxygen therapy, ni kwamba the main goal of administering oxygen therapy ni kuhakikisha kwamba we are reaching the target ya oxygen saturation ambayo tunataka. Hiyo ndio main goal. So kama nilivyosema, if you are dealing with the patient who is having COPD, amekuja na let's say saturation of let's say 72 or 77, so your goal is to make sure that you are reaching a target ambayo is acceptable for a patient with COPD, and for this case ina maana ni between 88 to 90%. Na unapokuwa na mgonjwa mwenye ARDS, for instance, ana COVID infections, amekuja na ARDS with saturation of 87, ukishamweka kwenye oxygen, your target should be above 90%. We know the normal range should be above 95%, lakini kwa wenye ARDS anything above 90 is acceptable. Na unapokuwa na mama ambaye ni mjamzito kama nilivyosema, na unampa oxygen, your target kwa kidogo, target yetu inakuwa iko juu almost kwa wale ambao ni normal ambayo ni above 94%. Kwa hiyo ndo target yetu ya wakati tunatoa oxygen. Okay, for patients who are pregnant, COPD and shock, So I don't think the time will allow us to look on this video, Alana. Maybe we can association curve. If the time allows, we can go back. But for now, let's skip this video. For 11 minutes, we cannot do this. Okay, Alana, can we proceed, Alana? So for those who have time, mnaweza mkapitia kwenye hiyo link, and then you can watch the video. This is just oxygen dissociation curve we have seen, tumevisoma kwenye mashule, kwa hiyo tunaweza tukavipitia. Now let me welcome Dr. Rebecca. Dr. Rebecca, as I said, she's an anesthesiologist at Bugando Zone Referral Hospital. She will take us through the next part of this session, ambayo ni kuhusu when to start oxygen therapy, how will you titrate the oxygen therapy, the hypoxamic, we have already have an introduction, and the duration of oxygen therapy. Dr. Rebecca, you're welcome.
Thank you so much, Dr. Saria. Naona kuna mtu amenyosha mkono, sijajua kama ana swali.
Dr. Mlacha, you are welcome. If you have any question, you can ask, please. Okay, Rebecca, unaweza kaendelea.
Asante. Okay, naona hapo kuna swali pia tunaona hapo limekuwa projected. Answer the question, in which of the following situations should supplemental oxygen therapy be started? Labda kabla tujaanza, kama nilipotambulishwa, naitwa Dr. Rebecca, niko Bugando. So tuendelee na kujibu hilo swali. In which of the following situations should supplemental oxygen therapy be started? You can just drop your answer na tutaona. Kuna A hapo, when the SpO2 is less than 92, when partial pressure of oxygen is less than 60 millimeter mercury, when the patient is in respiratory distress and the saturation is SpO2 is unavailable. D, when the patient is in shock, or the above. Na kuna mmoja nimeona hapo amejibu, Prosper Masawe. Karibuni wengine pia. Asante Mlacha. Okay. Sekunde 20. Kwa wengine ambao unaweza pia mkajibu. Just free to answer any option. Uwe tu free, and don't worry anything. Asante Rollins. Asante Silimbo. Okay. Okay. Okay, Alacha, can you share the results then before we proceed? Thank you so much. So 50% has answered answer A when SpO2 is 92, less than 92. And kama tunavyoona hapo 16% wamesema when the partial pressure of oxygen is less than 60. Now 33% answer E, ambayo ni all the above. Kwa maana hizo options zote ni true. So the answer here is E. The partial pressure of oxygen is less than 60. That is also hypoxemia. Kwa hiyo hapo lazima pia umwanzishie mgonjwa oxygen. So lakini pia mgonjwa anapokuwa na respiratory distress na hauna saturation, una SpO2 level saturation, the best way ya kumsaidia mgonjwa ni kumpa oxygen, because you don't know at that level saturation yake iko vipi. So haitakuwa contraindicated kumpa mgonjwa ambao unamuona kabisa yuko kwenye obvious respiratory distress. Lakini pia mgonjwa anapokuwa kwenye shock, tunajua kabisa pathophysiology shock it can affect circulation, lakini mwisho wa siku the lungs also will be affected, kwa maana kwamba perfusions hata kwenye lung zitakuwa affected. So you have to give also oxygen, kujaribu kuimprove oxygenation na perfusion pia kwenye lungs. So all the above are options za kutoa oxygen. Alana, can we go to the next one? Okay, thank you. So the next question says, how often should the oxygen saturation be monitored? And how do you titrate oxygen up? And how do you titrate oxygen down? Natamani mtu mmoja angeongea au wawili tusikie. So if anybody want to share or want to discuss wenye hilo swali, nikipata at least watu wawili, then we can proceed. Anyone who want to volunteer, just unmute your mic. Now utuambie, how often should we monitor oxygen saturation, and how should we titrate up, and how should we titrate down oxygen? Is there anybody who is ready to do that? Naona kama mkichati inaweza kawa sentence ndefu, bora ukiongea. Please. Anyone, please? Okay, if you are free, you also can chat. So mbaya. Kama mtu anaweza tu akaandika chochote. Also, I welcome. For 1 minute, you can use to discuss this question before we go to the conclusion. How often should the oxygen saturation be monitored? And how do you titrate oxygen up? And how do you titrate oxygen down? Wapendwa. Okay, ikisha dakika moja then nitajua. Be silent, then we can proceed. Okay. Asante Yasini. Yasini amesema 2 minutes. Nadhani anamaanisha we should monitor for 2 minutes. Okay. Sijajua kama kuna mwingine anataka kusema chochote. Okay, Alana, can you take us the recommendation so that we can save time? Just go straight to the recommendation 3. Okay. So jamani, tunapokuwa tumemweka mgonjwa kwenye oxygen, tunatakiwa tu monitor all the time. Okay, so hapo recommendation namba 3 inasema oxygen saturation should be considered a vital sign. So the way unapo monitor vital signs zingine, heart rate, blood pressure, is the same way you have to monitor oxygen. So saturation of oxygen hiyo lazima pia iwe monitored kama vital signs zingine zinapokuwa monitored. So kama una monitor zingine continuous, you do it continuous. If it's 2 minutes, if it's 3 minutes, is a vital sign. So unapokuwa una chart vital signs zingine kwa mgonjwa, remember also pulse oxygen saturation is one of the vital signs, and it has to be monitored continuously. Okay, thank you, Alana. Let's go back to the question. Okay. Now, how do you titrate up and down? Inategemea na target. Kwamba kama una target yako ni 92 to 96 na amevuka target, labda yuko 98, 99, you can start lowering the FiO2. Kama ulikuwa umempa lita 6 na unaona saturation yake imefika mpaka 98, 99, na wewe target yako ilikuwa ni 96, labda 92 mpaka 96, unaweza ukaanza kupunguza flow ya oxygen. Lakini ukipunguza pia flow au umempa flow labda leo umempa 4 liter per minute na unaona hajafika target ya oxygen saturation ambayo unaitaka, ambayo Dr. Saria aliongelea kwa mgonjwa wako, then you can increase the flow ili uweze kufikia target yako ambayo umefikia. Kwa titration ya flow au ya oxygen therapy inategemea na target yako ambayo unataka kuifikia. Ukiwa umeshavuka target, then titrate kwenda chini, lakini kama haujafika target, always go up au change device ya delivery ya oxygen ambayo unaitumia. Kama ulikuwa unatumia nazo cannula, you can move ukaenda kutumia oxygen face mask, simple face mask. Ukiona haileti matokeo ambayo unayataka, you can move to rebreather mask, or you can go up with ventilation, kutumia the non-invasive ventilation. So the next question is, how long should oxygen be provided to a patient that is hypoxamic? Just for 30 seconds. Anyone can reply this. So how long should oxygen be provided to a patient that is hypoxamic? Mgonjwa yuko hypoxamic, tunampa oxygen kwa muda gani? Just drop your answer kwenye chat box hapo, mimi nitaona. Na ni watoe hofu kabisa, jibu lolote lile ni sawa, na tunadhamini hakuna mtu atakaye challenge jibu la mtu yoyote yule. So just be free kuandika kile ambacho wewe unafikiri ni sawa. Tunajifunza wote, so be free to write. Suniva, nimeona umeinua mkono, karibu. Suniva. Hello Suniva. Unaweza ukanmute microphone na kuongea, au kama unauliza swali au kama ni comment, karibu.
Okay, my mic was not unmuted, so now it's on.
Okay, thank you.
Oxygen can be provided to the patient continuous until when the saturation is almost from 85 and above in the blood.
You mean the SpO2, the SpO2, right?
Yes.
Above 85.
Yes.
Asante sana. Thank you so much for your responses, Univa. Kuna mtu Prosper ameandika depends on patient response. Okay. So kikubwa ni kwamba unapotoa, when you're providing oxygen to a patient, you have to make sure at least you are achieving the goal you are targeting. So kama Dr. Saria alivyostrain kwamba if the patient is COPD, now it depends which kind of patient are you dealing with. Kama ni COPD, we know the range of the saturation where we want to reach. And if it's an acute hypoxemia or hypoxia, again, we all know the target. Kwamba ni at least tufike 92% to 96%. Na kwa COPD tumeona kwamba it has to range between 88 to 92. So if you are dealing with the pregnant mother again, or other shock patient, at least your saturation has to be above 94. So it depends on what kind of patient are you oxygenating. So for how long? Until you have reached your target. So you will continue being on oxygen until you have reached your target ambayo wewe unaitaka kufikia hiyo target. Otherwise, hawezi kusema tumempa mgonjwa for 1 month, sasa saturation yake naona ha improve, so let us stop. No, we don't do that. Lazima tutaendelea kumpa oxygenation. Tutakachokuwa kifanya labda ni kuchange devices to higher devices of delivering oxygen. We can change the method of delivering just to make sure we are achieving the target we want to reach for oxygen therapy. So thank you so much all. We'll respond. Alana, next.
Okay, so Rebecca, would you like to proceed, or can you take a rest and then I proceed?
Okay, you can proceed, Saria. No.
Okay, so Alana, can we proceed now? Okay, so we are moving to the third part of our session today. And this time we're going to discuss about the non-invasive oxygen therapy, the issue of humidification, and awake prone position. Remember, this oxygen therapy series, we are talking about mostly our focus is to the patient with acute respiratory distress syndrome and who are receiving oxygen. So there will be a time when this patient also they'll need to be put in the prone position. So we'll see how and why we put the patient in prone position. So the question is, so what are the different types of non-invasive oxygen therapy? How do they differ in terms of dosage and devices needed, and the disadvantage of each? If you remember from the previous sessions, to discuss more about this oxygen delivery devices, we have invasive and non-invasive oxygen delivery system. And for non-invasive now, if you remember correctly, we had like 4 or 5 methods or devices which we can deliver oxygen to the patient, and this including simple mask, non-rebreathe, and BiPAP mask. So these are the non-invasive devices. Now, my question to you all is, how do they differ in terms of dosage and devices needed? I've already outlined the devices. Now, your task is to tell me how do doses differ from each type of each devices. Tunaomba hapo kwenye chat at least in few minutes mtuelezee hizo devices zinaweza zikatoa kiasi gani. How do they differ in terms of dosage and devices needed? Remember, the oxygen saturation of the patient might determine, or the consumption of oxygen in terms of liters per minute may determine which devices to use. Let me just proceed. Kama tulivyoona, tunazo nasoplunge ambazo can go up to 1 to 2 up to 3 or 4 liters per minute, and then we have simple mask which can go from 6 to 10 liters per minute, and then we have non-rebreather mask which you can go up to 15 liters per minute. So when we are using more than 15 liters per unit, now we have to use what we call the high flow nasal catheters, which can deliver up to 60 liters per minute. So these are the devices and the dosage which they deliver, and their usage now depend on the circumstances. So if the patient is saturating well on nasal plunge, which is 2 to 3 liters up to 4 liters per minute, there's no need of going up and using the other devices. But when you put the patient into nasal breather, into nasal cannula or nasal plunge, and you think that the patient is not improving, you want to change your device, or you are not meeting the target of oxygen saturation, then you have to change the devices, and then you continue doing so until you reach your target of oxygen saturation. And the advantage and disadvantage of each depend on the environment. So there are some devices which you cannot deliver oxygen, depend on for instance, if you don't have the cylinders, for instance, you have only the oxygen concentrators. There are some devices you cannot use in your oxygen concentrators. And when you have the issue of contamination, decontamination, or whatever. So we'll share the link whereby you can go through these advantages and advantages of each, because we have only 1 hour here. We cannot discuss each and everything. And the next question, which of the following is in the correct order for least FiO2 to highest FiO2? Now, I'm sure this one, everyone can respond to this question. Please, I'm just waiting for your response. Yes, please. Can you arrange these devices in order for the least FiO2 to highest FiO2 delivery? Okay, someone say nasal plunge, simple mask, non-rebreather. Okay. Do we have any other response different from the one? Okay, nasal plunge, simple mask, non-rebreather. And if you attend the previous session, I'm sure this option, this question will be very, very, very easy for you to attempt, because I'm sure you remember we discussed this in the previous session 1 or our session 2 of this series. We discussed about the oxygen delivery devices and their fraction of inspired oxygen concentration which can deliver. So for the sake of time, it's true that the nasal plunge is the least one, followed by simple mask, and then non-rebreather. So if you're using nasal plunge, as you remember, you can just deliver oxygen up to 4 liters or 5 liters per minute. The amount, the fraction of inspired oxygen they can give is 35 up to 40%. And when we are using a simple mask, it can give you up to 60% of fraction of inspired oxygen concentration. And when we are using a non-rebreather mask, it can give up to 98, 99% percent of inspired oxygen concentration. So the correct answer will be an option A, whereby all majority of those who responded, they choose the one. Okay. Okay, Alan, can we proceed? So the other issue is, when is humidification needed for oxygen therapy, and why is humidification needed? Kwa hiyo tunajua kabisa, if you remember the anatomy of the respiratory system, we have the upper respiratory tract, and for the upper respiratory tract, it's just a conduit for the oxygen passage. And when the oxygen is passing through the upper respiratory tract, one of the issues is it usually being filtered and humidified. Kwa sababu we are not breathing a dry oxygen or a cold oxygen. So it has to be humidified and filtered. And this is the main function of the upper respiratory system in the nose. So if you are giving oxygen to the patient, please make sure that you are using the humidifier bottles to humidify the oxygen. So when you are giving more than 3 liters or 5 liters per minute, this has to be humidified. Or if you are anticipating to give oxygen for a prolonged period of time, then you have to make sure that you are humidifying the oxygen. Why? Is because we want to avoid to give the dry oxygen to the patient. We know that if you are giving the dry oxygen, it may cause drying of the mucosa, the secretions in the respiratory tract. They can form the plaques and also increase the work of breathing. And also it may cause bleeding, especially when you are giving high flow oxygen, for instance, 15 liters per minute or 60 liters per minute. This is a very dry oxygen. If you're not humidified, it may cause damage to the mucosa and the patient might start bleeding, okay? So the next question is, can humidification bottles be reused? How do you set up humidification if there's no sterile water? So it is true that we can reuse. There are different types of humidifying bottles. We have the single-use humidifying bottle. We have the reusable humidifying bottle. So the issue is, when we are using a reusable humidifying bottle, we have to make sure that we clean it, we decontaminate it, because otherwise it may be the main source of infection, you see. So we have to make sure that we decontaminated it, and then we are using the sterile water. Of course, when there's no sterile water, what we can use is, we can take a tap water, you boil it to 100 degrees Celsius, and then you let it cool, and then you take the water and put in the humidified bottle. Maybe Alana, you can share with us the recommendation from this one. You see, these are the recommendation when it comes to the user. This humidified bottle. So if you're using okay, so can you scroll to the humidified bottle? So you can see from this recommendation by the WHO that if you are using a reusable humidified bottle, there are some steps you have to do it. And the main issue is you have to decontaminate it to make sure that it will not be the source of infection. And when you don't have the clean sterile water, the distilled water, most of the time we are using distilled water for humidification. But if you don't have the distilled water, you can still use the tap water. As I said, we need to boil it, let it cool, and take the water and put it into the humidified bottles. So, and this is the way you can purify the bottles. You see, there is this technical specification for the usable. So these are the links which Alana will share with us. We can go through it, and then you can see the recommendation and why we need to decontaminate it. And you can see also the importance of using humidification when you are giving high flow oxygen therapy. Thank you, Alana. Can we go back to our objectives? So you can see now we are about to wind up our presentation. Now, what about awakening prone position? Where should this be tried? How is it done? So as I said, most of the time we will be discussing most of this acute respiratory syndrome. Now, Wakika, most of us have seen this patient or we have attended these patients. Sometimes when they are lying in supine position, their saturation, even if they're in high flow oxygen therapy, their saturation are not improving that much. And once you put the patient into a prone position, you will start seeing the difference. You can start seeing the improvement of the oxygen therapy. Why? Is because when you are lying flat, you are increasing the VQ, or you're increasing shunt, VQ mismatch. Ventilation and perfusion would be mismatched. Hence, there'll be no increase in saturation. But when you are put the patient into a prone position, that means you are giving the patient, you are opening the alveoli, you're opening the airways. And when you are opening the airways, the alveoli, you are increasing the surface area for oxygen delivery. And hence, for oxygen delivered to the blood, this is ventilation. And then also you're increasing the chance of this oxygen to be picked up into the blood. Thence you're increasing and hence you will see the increase or the improve of oxygen saturation. So the recommendation is that you have to make sure that the patient is prone for at least 6-8 hours in a day, lying on the Coctomia tumbo, and then you give it some times, then you assess. Of course, you have to give the patient a resting time, because the patient cannot lie in supine for the rest of the day. So you have to make sure that at least 6-8 hours, then you reassess the patient, and then you assess the patient and manage accordingly. So you have to individualize the care. So this is how this the Alana will share also the link, and then you will see how is it done. And okay, so Alana has shared the link on the prone position. Is a flow diagram which show how this patient has been could be treated. So if the FiO2, for instance, is more than 28% or require basic respiratory support to achieve the SpO2 92 to 98%, then there's no need of lying in the prone position. But if it's yes, you can see that is mean the demand is too high. You have to put the patient in a supine position, and then you, as I said, you reassess your patient based on the FiO2 and the SpO2 you are getting from the monitor. If it continue to be low, you continue with prone position. If it improve, then there's no need of putting the patient into prone position. So this is a flow chart. I think so you can download it, and then you can even laminate it and put it in your working place, so that it can guide you on how and when and at what time to put the patient in a prone position. Thank you, Alana, for sharing. Okay. All right, can we go back to okay, now, Dr. Rebecca, are you still there?
Yes, I'm here.
Okay, now can you take us through the fourth, I think, or the fifth part of therapy, high flow in devices, indication for intubation and mechanical ventilation. Thank you.
Okay, thank you so much. So let's proceed as the question states. Now we are going to discuss about the escalation of oxygen therapy, high flow oxygen devices, which we've already discussed. Also, it will be repetition. So when should oxygen therapy be escalated? Maybe one or few comments. When should oxygen therapy be escalated? I think also we have somehow touched about this. So I don't think we are going to waste so much time here again. Anyone with an idea? Okay, tumeona in the previous kwamba when you have to escalate oxygen therapy when you have not reached your target. So if you have a patient who is hypoxamic, the saturation is below. Now, depending on the kind of patient, for those patients with chronic lung disease, and always those who don't need too much oxygen, they are at risk of hypoxamic. You don't need to give them much oxygen, and usually the target, as we said, has to be between 88 to 92%. So you will escalate to higher levels if you have not reached that target. So usually we start with we have learned about different delivery devices, method of oxygen. So you can choose either to start with the nasal cannula, or you can start with the oxygen simple face mask to give. You end up there. So if you haven't reached your target, you can proceed with other higher devices. And usually, as we have discussed, that the target has to be between 88 and 92%. So remember, always for an hypoxamic patient, remember, if you have a device or you have facilities to do, or you have accessory, or you have access to ABG, arterial blood gas, it's also better to do it so that you can see the pH and the level of partial pressure of carbon dioxide in blood. Okay. So when you are dealing with other acute hypoxemic cases, which are not chronic lung disease, they're not COPD, and the patients are not at risk of hypoxamic respiratory failure, then usually our target for oxygenation is usually, it has to range between 92 and 90 to 96%, as I say. So if the saturation is below 85, you select devices according to what the patient. So you can start with another cannula, you can use simple face mask, you can use non-rebreather devices to deliver oxygen, but just to make sure you target the range of oxygen you desire. So if the saturation is between, again, 85 to 91, you have to give oxygen, because we have discussed that this patient, the target has to be 92% to 96. So this patient will require, again, oxygen. But for those whose patient, the range of oxygen is above 92%, this patient usually, we don't give them oxygen, but they need to be monitored closely so that whenever they go below 92, you have to administer oxygen to them. So they have to be on saturation monitoring all the time to see how they range. If the saturation has dropped to below 92, immediately you have to start oxygen therapy using different devices you have. You can start with the low oxygen delivery devices, the oxygen nasal cannula or nasal prong, or you can go to higher flow devices. Remember, again, in all cases, those patients who are hypoxemic, if you have access to arterial blood gas, is the best way to do arterial blood gas again to measure their partial pressure of carbon dioxide, also the pH in blood. And if all other delivery of oxygen has failed, you can go to non-invasive method or invasive method, just to make sure you have reached the target oxygenation. Yes, Alana, thank you. I think Alana has shared the link to this again, so you can access this material at your own time and go in detail. So the next question was, which devices use high flow oxygen? Which devices use high? I would like to see the comments from you. Anyone to respond on this? We have learned through devices, I think several times. Now I want us to mention those devices which use high flow oxygen. So for a few seconds, you can just drop your comments on the chat box. When we say high flow oxygen devices, what are they? Karibuni. So nataka tu mvitaje vile vifaa ambavyo vinatumia high flow oxygen. Okay, Prosper Asante amesema CPAP device. Anyone to respond? Karibuni For 20 seconds, I'll be waiting for your response. Okay. So, okay, there's another comment. Okay. Kuna mtu amenyosha mkono. Happy Hospital. Happy, do you want to talk something? Happiness, umepotea tena. Okay.
I think Rebecca, for the sake of that,
For the sake of time. Okay, so when we say high oxygen, we have high and low flow oxygen devices. Tunaposema low oxygen delivery devices, hapa tunamaanisha ni zile nasal cannula au nasal catheters, lakini pia kuna zile zinazoitwa na hii ni nasal cannula au nasal catheter. Na when we say high flow devices, tunaanzia zile ambazo zinatumia flow above 6 liters, from 6 liters and above. So from 6 liters and above, hizi ni zile ambazo zina include simple face mask, non-reservoir oxygen face mask, tuna venturi mask pia, lakini zenyewe pia hizi venturi pia zinategemeana. Kuna ambazo zina deliver low, lakini kuna ambazo zina deliver high flow. Kuna hizo non-invasive kama CPAP zina deliver high flow, lakini pia hata mechanical ventilation au mechanical ventilators zina deliver high flow. So kwa oxygen devices tunaanzia kwenye face mask, non-reservoir, venturi mask na CPAP mask, zote zile zina deliver high flow oxygen. Na tunaposema low flow ni those 5 and below, or below 5 liters per minute, they are low flow devices. They include nasal cannula, nasal catheters. Another question here is, how long should it take for saturation to improve? And when should a patient be intubated? Labda hilo swala la kwanza tuliskip. Naomba tu mniambie, when should a patient be intubated on mechanical ventilator? Hilo la kwanza nitawasaidia kujibu. So when should a patient be intubated? Ni wakati gani tunaamua kumweka mgonjwa kwenye mechanical ventilator? Lakini pia anayejisikia kujibu part 1, karibu. You can answer any part. You can answer part 1, you can answer part 2. For 15 seconds. Kama kuna mtu anajibu. When the patient is still saturated while on high flow oxygen therapy. Nadhani anamaanisha kwamba hapa sasa ndio ambako tunaamua kumintubate patient. Okay, thank you so much, Grossman, for your very good response on this. Okay, so how long should it take for SpO2 to improve? It depends again. So if you, okay, Alana, can you take us through that part? Tukaangalia water. There's a video there we can watch. I don't know for how long it is. So let's listen to this video. Let's watch.
Before discussing airway management and modes of mechanical ventilation, it is important to review the indications for intubation and mechanical ventilatory support. The indications for intubation and mechanical ventilation: hypoxic respiratory failure, hypercarbic respiratory failure, airway protection, and a non-sustainable work of breathing. Hypoxemia is defined as a partial pressure of arterial oxygen less than 60 millimeters of mercury, or an SpO2 or oxygen saturation less than 94% by pulse oximetry. Although an SpO2 less than 94% defines hypoxemia, oxygen therapies and mechanical ventilation may not be indicated until more severe hypoxemia occurs or respiratory failure becomes evident. Causes of hypoxemia include decreased inhaled oxygen, alveolar hypoventilation, and VQ mismatch. VQ mismatch includes both dead space and shunt. Is common in several pathologic clinical states, including pneumonia, ARDS, and pulmonary emboli. Hypercarbia is defined as a partial pressure of arterial carbon dioxide greater than 45 millimeters of mercury, as measured on arterial blood gas analysis. Hypercarbia is common in COPD, emphysema, and hypoventilation. Common causes of hypoventilation include medications, altered mental status, head injury, and severe metabolic derangements such as hypoglycemia or myxedema coma. Patients often need to be intubated and mechanically ventilated for airway protection. Patients with altered mental status may have associated hypoventilation and inability to clear secretions. Further, obtunded patients in the supine of the tongue and soft tissues of the posterior oropharynx, which fall backwards, obstructing airflow. Examples where airway protection may be needed include stroke, head injury, sedation, overmedication, and anesthesia. Patients with a non-sustainable work of breathing may need to be intubated and mechanically ventilated. Patients struggling to oxygenate, ventilate, balance a metabolic acidosis, or overcome airway obstruction, mechanical ventilation. Struggling patients demonstrate any or all of the following characteristics: a high minute ventilation with an increased number of breaths per minute, an inability to speak in full sentences, and obvious accessory muscle use. Pathologic examples include status asthmaticus and severe metabolic acidosis.
Okay. Thank you so much, Alan. I think we have all watched the video and at least tumepata overview ya indications za intubation or indications za kumweka mgonjwa kwenye mechanical ventilation. Okay. So how should it improve oxygen? Or how long should it take for oxygen to improve? Inategemea na condition alionayo. They differ, hakuna constant time. Lakini once you see that the patient has those indications we have seen on the video, mgonjwa anapata respiratory failure or hypoxemia, au ana air obstruction because of sedation, because he's unconscious in trauma, au amepata stroke, hawezi protect airway, ana hypoventilation, ana poor work of breathing for different reasons, labda either amekuwa oversedated au ana muscle diseases. You have to consider putting this patient on mechanical ventilation. Kwa indications za kwenye ventilation ni pale ambapo unaona kabisa kwamba the patient cannot maintain by his or her own better ventilation. So he cannot maintain ventilation. You have to consider putting that patient on mechanical ventilation, regardless amekaa muda gani kwenye oxygen. You can put the patient on oxygen for just 10 minutes and you decide to intubate. Some patients can be kept on oxygen for 1 week, then they deteriorate. We consider putting them on mechanical ventilation. So there is no exact cut time. The patient akikaa muda kwenye oxygen, then you consider ventilation. The only indication is when you see those indications ambazo tunamuona kama mgonjwa hawezi ku maintain ventilation. Yeye mwenyewe is putting that patient on ventilation. Okay, so next, I don't know what the next is. Alana, let's move forward.
So, okay, Rebecca, can you take us through in less than 5 minutes on oxygen supply, oxygen safety, rebreathing carbon dioxide, reusing?
Okay, let's see. So, what are the safety concerns when using oxygen? Okay. Vitu gani ambavyo ni vya msingi tunaviangalia vya kiusalama tunapotumia oxygen therapy? Can Alana just send to that page ili niweze kusummarize if possible in just few minutes the whole thing. Tunatumia kwamba tunapotumia oxygen zinakuja katika devices tofauti tofauti, so lazima pia tujue the safety measures of how to use when we are using oxygen. Tujue kabisa kwamba inategemea oxygen inakuja katika form ipi. Kama unatumia kuna safety issues za namna ya kuhandle zile mitungi. If you are using concentrators, there are things you need to consider when you are using concentrator for safety. Zingine zinatumia umeme, zingine hazitumii umeme kama ambavyo tutaenda kuona. Sorry Alana, can you send us there? So that we can just discuss the whole thing about the oxygen devices. Okay. I think you can just go to the types of oxygen supply, then I'll just summarize the safety there together. Go to page 12. Okay. Alana, go to page 12. And what types of oxygen therapy supply are available? Yes, I will just talk the safety there. So wakati Alana bado anatupeka kwenye ile page, tujue kwamba tuna different sources za oxygen therapy. Tuna oxygen cylinders, we have tuna concentrators, lakini pia we have oxygen plants na tuna zile tunajizaga liquid oxygen tanks ambazo ni device ambazo zinatoa okay. Okay.
Nafikiri Rebecca unaweza tukasummarize tu hapo without even using the
summarize kutokea hapo, haina shida. Okay, ni kwanza zile sources zile main, okay? Sawa. So tuna plant lakini tuna oxygen concentrator, tunatumia pia cylinders. Sasa cylinders kama tunavyofahamu, cylinders kutumia haihitaji umeme. Ila safety features zake kwanza ni kwenye ubebaji. Lazima ile mitungi inatakiwa iwe imesimamishwa na haitakiwi kulazwa. Okay? Lakini pia usipokuwa makini mitungi inaweza kuangukia. Ile ni mizito, ikianguka chini inasababisha ajali. So you have to ambako mna store mitungi iwe ni sehemu ambayo ni salama na hakuna movement za watu ili waweze kuigonga ile mitungi na kudondokea watu au kudondokea vitu na vikasababisha ajali. Lakini pia inakuwa ukishaifungua ukafungua flow meter ikaanza kuflow, jamani tunafahamu kabisa oxygen ina support combustion. Kwa hiyo ukiwasha moto au ukavuta sigara karibu na sehemu ambako kuna mitungi inatumika, unaweza kusababisha ajali ya moto. Kwa hivyo ndio vitu vya usalama. Kwa unapotumia oxygen therapy hakikisha hakuna moto karibu unaowaka, kwa sababu yenyewe pia itasapoti ule moto kuwaka. Kwa hivyo ndio vitu vya msingi vya kuangalia. Lakini unapotumia concentrators hii matumizi yake yawe mazuri, unahitaji kuwa na source ya umeme. Kwa hiyo ni tofauti na cylinders. Cylinders unaweza kutumia hata sehemu hamna umeme, as long as una flow meters au una regulators you can use oxygen cylinder. Tofauti na concentrator. Concentrator inahitaji uwe na source ya umeme. Umeme ukikatika yenyewe haina backup battery, huwa inazima na unakuwa hauna source yote ya oxygen. Kwa hiyo unapokuwa na concentrator lazima pia uwe na cylinder kama backup source. Hiyo ni kwa usalama wa mgonjwa, kwamba unapokuwa unatumia sources ambazo unapokuwa na source mojawapo ya oxygen lazima uwe na backup source pia ya pili. Na hata kama unakuwa na oxygen plant, kwa mfano kama una oxygen plant ambayo imewekwa somewhere, kwanza oxygen plant ku maintain ni costful kwa sababu inahitaji watu ambao ni wataalamu, unahitaji biomedical engineer kuoperate, kuwa na piping kutoka kwenye plant mpaka kwenye source ambako unataka kupeleka hiyo oxygen yako. Kwa hiyo issue ya piping lazima ihusike, na wakati mwingine piping pia zina leak. Kwa hiyo utarudi pale pale kwamba unakuwa na oxygen plant lakini una upotevu wa oxygen kwa sababu ya leakage. Na ndio hasa complication kubwa ya plant kwamba zile piping zinapokuwa haziko vizuri unakuwa na leakage ya oxygen. Lakini pia hata kama una plant, wakati mwingine plant zina fail kuproduce oxygen inayotakiwa, na hivyo pia unahitaji kuwa na backup. Kwa kifupi, unapokuwa na source yote unaotumia, whether unatumia cylinder, unatumia concentrator, unatumia plant oxygen, lazima uwe na backup source ya oxygen kwa sababu hiyo source yako at one time inaweza ka fail ukahitaji source nyingine. Cylinders zinaweza kutumika kama okay, because of time. Thank you.
Yeah. Kwa hiyo jamani, for the sake of time ni kwamba hizi presentations zote tunashare kwenye groups, tunashare kwenye chat hapo, unaweza ukafuata hizo link. Now can we go to the last part of this presentation Alana? Sehemu ya mwisho ya kwenye hii presentation yetu inatuhusu kuhusu acute respiratory distress syndrome, the definition of ARDS and how to manage ARDS. Na unavyojua kabisa kwenye ARDS definition yake tunatumia zile criteria za Berlin na zile Berlin classification of ARDS, ambapo lazima mgonjwa awe ameugua for at least a week, afu lazima kwenye chest x-ray infiltrations, lakini hizi infiltrations zisiwe explained to cardiac issues, as you can see from that. Okay, so can you click on the first question, Alana? Kwa hiyo lazima kuna hizo Berlin classification or consensus how we define acute respiratory distress syndrome. Kama tulivyosema, kwanza lazima PA FiO2 ratio iwe less than 300. PA FiO2 ratio ni kwamba unaangalia unampa fraction, partial pressure kwenye oxygen kwenye damu iko kiasi gani na anapata FiO2 ya ngapi. Kwa hiyo ratio yake always should be less than 300. Ikiwa less than 300 inamaanisha ana mild acute respiratory distress syndrome. Ikiwa less than 200 ana moderate ARDS, na ikiwa less than 100 ana severe ARDS, kwa maana kwamba unampa oxygen nyingi lakini kiwango cha oxygen kwenye damu ni kidogo. Kwa ina maana ugonjwa ni mkubwa zaidi, ndio maana hiyo definition. Kwa hiyo define ARDS, kwanza lazima awe na hiyo PA FiO2 ratio of less than 300, lazima awe ameugua for at least a week, alafu lazima awe na hiyo lung opacification ambazo ni infiltration ya kwenye lungs ambazo haziwi explained by the cardiac causes. Yani causes za hizo infiltration or opacification is not a cardiac issue rather than is a respiratory issues. Hizo ndo jinsi ambavyo unaweza ukadefine kwamba mgonjwa amepata acute respiratory distress syndrome. Na monitoring yake kama tulivyosema ni hizi FiO2 pamoja na PA FiO2 ratio tunazozitumia zaidi katika kuzi define. Now, okay, Alana, can you go back to the last question? So how can ARDS be diagnosed when the arterial blood gas analysis is unavailable? Kama tulivyoona kwenye diagnosis ya ARDS, tunatumia partial pressure of oxygen in the blood, tunatafuta ratio yake kwa kutumia FiO2 ambayo tumempa mgonjwa. Sasa pale ambapo unakuwa hauna blood gas analysis ABG machine, inakuwa ni changamoto kidogo kudefine au kudefine, na hapo ndio inapokuja ile kitu kinaitwa ni modified Berlin classification of ARDS ambayo tunaitumia Kigali, tunaita Kigali kwa sababu when we are using the Kigali modified criteria, mara nyingi huwa hatuconsider sana partial pressure of oxygen into the circulation kwa sababu majority of facilities they don't have a ABG machine. Kwa hiyo mara nyingi tutaangalia sana ni SpO2. Kwa ile ratio ya PA to FiO2 ratio, hapa tutakuwa tunaangalia ratio ya SpO2 na FiO2 ambayo tunakuwa tunampa mgonjwa. lakini the other parameters zina remain the same. Kwa lazima umefanya chest x-ray, lazima the onset should be an acute one, na lazima kwamba awe na hizo criteria nyingine. Kwa so far hiyo ndio jinsi ambapo unaweza ukadiagnose ARDS in a situation whereby you don't have the arterial blood gas analysis. Having said so, unless if there's someone who has any questions, because I think that will make the end of our presentation for today. So if we don't have any, unless if you have any question, please, you can just ask. If you have any concern, you can just ask. If there's a somewhere but we haven't understood well, we can just elaborate it more. We still have the WhatsApp groups. We still have the Telegram group. We can still share our concern. We can still discuss the cases. We can still discuss the presentation on that platforms. But for the Zoom, I think this will be the end. And remember, the Anne Frank quote says, "How wonderful it is that nobody need wait a single moment before starting to improve the world." So this is a quote from Anne Frank. Okay, so far there's no any questions. I would like to take this opportunity to thank Dr. Rebecca for her time, I mean. And then also I would like to invite our colleague from Assist International to say anything or to give us any announcement if there is. Alana, you're welcome.
Yeah, thank you, Dr. Saria. So thank you to everyone who participated in the session today. Thank you, Dr. Saria, Dr. Rebecca, Dr. Lillian, for your help in teaching. If you would like to review the materials discussed today, including all of those extra links that we were showing on the screen, visit the Learning Resource Center. This website is free to access, and it contains a lot of resources, quizzes, exercises, and videos. So we encourage you to check that out. I will share the link in the chat. We also have a community group on WhatsApp where you can ask questions in between sessions. So again, we encourage you to do that. Go in here for helping us facilitate the session today. And thank you for Project Echo for funding the program. Our next session is on February 11th. We'll be talking about critical care outside the ICU, rapid response teams. So please save the date and we hope to see you then.
Thank you so much, Alana, and thank you everyone. Good evening, everyone.
Thank you all.